Okay, so for those who don't know, I'm Candace. I am currently the SIG chair for the Lymphedema SIG. Miss Paula Stout has agreed to join us today. She is kind of the APTA's oncology program's large advocate when it comes to the LTA that's been moving forward. So she has offered her time for us today to answer some questions, kind of tell us where the current advocacy is going, and maybe even give us some directions on how therapists can participate more with this movement forward to improve this legislation act. Um, a little bit just for a little bit of background, I'm going to pull up a presentation just because some people joining might not be so like highly specific in lymphedema therapy. They might be more focused on other components of oncology care or just general care altogether. So I want to run through the Lymphedema Treatment Act, but before we do that, just a little bit of housekeeping stuff. When it comes to the lymphedema SIG right now, one of the things we're wanting to do is kind of create these open moments together so we can all kind of come together, talk, and chat. So our leadership team was looking into ways to kind of create that connection. And we thought maybe these small webinars, kind of informal, a little bit more easy, kind of more question-based webinars would be a good way to do that. If any of you all have any specific recommendations, something you would like to discuss openly, be it case reporting or be it, modalities in therapy, feel free to shoot the leadership, and we're available on the Oncology Academy. You also get the Gmail, LympSig Gmail notes from us. Feel free to shoot any of those an email, and we'll be more than glad to kind of start working those into a generalized schedule. We want to participate more, but we also don't want to overwhelm everyone in terms of more stuff to do. So we want it to be very specific to what our therapists want to be involved in. Real quick, in case you didn't catch the oncology blast, there's some really great things that are coming out for the APTA oncology group. They are looking at a whole series over the summer regarding bone health and osteoporosis and osteopenia is the first one, and that's coming up on the 15th. If you have a chance, you can register for it, and Susie with the info at oncologypt.org is the one who sends out those blasts to us, and that's available on there so you can follow those links. There is also a partnership with IPT Hope. This one's on cancer-related fatigue. It's also on the blast. Please consider checking it out if you have a chance. It's actually coming up just this Saturday. And then we have a whole specialization group. Yeah, Miss Paula's like, she's actually kind of taken the charge on this with a couple other people. But with the specialization, we have to maintain specialization by keeping the exam questions relevant, making sure the current questions are actually up to date with the correct information. And that takes a large workload. She might be able to speak more on that if she has anything to add, but they're always looking for people to join. And it does actually help towards your own maintenance of your accreditation or your specialization. So if you have some time and if you're looking for a way to get involved, this is a very low intensity kind of good way to kind of get your foot in that door with complete guidance on people who have experience doing this to kind of help you the entire time. That also includes an item writing workshop. They're having one in October, which is a little bit of a ways away, but considering it's a Saturday, we wanted to go ahead and give people a chance to kind of start blocking off their calendars. But I believe, Miss Paula, you might want to correct me, that's a one-on-one session with you all to kind of go over the process and actually help with direct item writing on that day and things like that.
Yeah, so the item writing workshop is something you don't have to already have applied to be a writer. You can just come to that. And by one-on-one, Candace, that's a good way to put it because our specialty panel will be on there with you and help you. Like if you, we want you to come to the session with some questions already kind of partially written if you can, and we can help you guide you on that. But if you're like, I don't even know if I want to be an item writer. What does this mean? Just get on the workshop and we'll guide you through it.
Yeah. Thank you. Sorry to throw you on the spot, but I just realized you know a lot more about that one than I do. So
No, no, that's wonderful because we do. We need item writers. We need you guys to, just contribute to those questions, those clinical scenarios for the test.
So just kind of a brief review for the LTA for those who might benefit from it. In 2024, Medicare did start covering compression items. They cover daytime items, they're covering nighttime items, they're covering bandage supplies and garment accessories. And we will get into the nitty-gritty of what that means kind of a little bit later on in relation to the suppliers of those items. But Medicare's rule basically says that we get 3 per body region every 6 months. And for those who might not be too terribly experienced with this, that per body region region is a wonderful definition because it means that an arm sleeve and a glove are two separate parts. It means the foot, the leg, the knee, the thigh are separate parts. And so you can really work with layering garments for this for both day and night. So even though three, I mean, that's kind of what we want for patients anyway. Patients can get a lot more benefit from this, especially when they're looking at total lower body care or upper body and chest care. That does include custom, off the shelf, elastic, and elastic for both day and nighttime. Nighttime's a little different. We don't need to re-up our nighttime as much as we often do our daytime. So it's two every 2 years. And the bandaging supplies are as needed, but that is a very thorough documentation that needs to be done for the need, and you have to be very clear about what you want. And again, we'll talk about that in a little bit. And then the garment accessories is also, you have to be very clear about what you need, but that includes donning and doffing aids, adding zippers and liners to items. That includes lymph pads if you need to add an actual pad or some sort of swell spot type contraption to an area. Um, when it comes down to the actual requesting of this, as therapists, we have to have certain things in our documentation, and the number one is the diagnosis codes. There are a lot of DMEs that are now shutting doors on anything besides these diagnosis codes because when it's affiliated with Medicare at this point, they're just refusing to take anything beyond there. So you'll probably have a hard time getting coverage for something that's not one of these four through a Medicare-based payer. You do need a very consistent prescription, and it doesn't have to have brand and things like that, but it needs to have the concepts of what's being done, the type of garment you're getting, the compression intensity you're getting, the features you're getting for that garment that might be specific as to why this specific feature is needed over a basic level feature of that garment. Laterality is needed. There's a lot of different specifics. And honestly, it's worth, if you're not familiar with doing this, talking to the DME that you're using to get more specific from them. Because some people even offer a prescription page that you can then complete on their behalf to make your life a little easier. And then, of course, clinical notes is probably the most important thing out of all of this. The diagnosis code should ideally be on your clinical notes, but your clinical notes have to really support what you're asking for. And when you're looking at the clinical notes, it's not only the features, but you have to kind of explain why a custom item might be more important than an off the shelf based on refill time or texture or shade. So those notes have to support that. Regarding what the patients have to deal with, I'm still finding 2 years out. I just had a patient today who has no idea that her compression's now covered. So it was a pleasant surprise for her. But the Medicare Part B coverage is an 80% coverage, and that is after they meet their deductible. Supplementals often do cover the remaining of the 20%, but there have been instances where not necessarily a Medicare supplemental, but another option for supplemental or secondary coverage might not cover that same rate. So you have to work with your DME supplier to kind of make sure you know what the patient's being covered under. And then I think we all kind of roll our eyes when it comes to the Advantage plans because we know the problems we have with them. But in regards of compression garment coverage, the main difference that I'm seeing in my own space is the coverage is roughly the same for a lot of patients. It's the price that they're paying is different. Some of them have a cheaper expense than the 80%. Some of them have a higher expense than the 80%. But technically, the Advantage plans aren't required to have the same level of coverage. So you might go through the process of making a request to find out your patient has very little coverage compared to what the Lymphedema Treatment Act actually supports for Medicare patients. A lot of patients do struggle to understand what coverage is and why it is. As therapists, we don't necessarily have to get into the nitty-gritty with them on that, but HCPCS codes is how that's all determined. So if you're not familiar with that, there is a list on the Medicare webpage regarding the lymphedema treatment coverage of codes that are approved. So there are some items out there that are not approved by these HCPCS codes. So even if you try to go through them, the DME suppliers will not request for coverage for that. So you have to know and have access to which codes are appropriate. But the good news is the majority of the important codes we see as lymphedema therapists are on there. And then you also have to go through a Medicare a supplier for DME that has gone through the process with Medicare to be covered. So that's another step that these suppliers have had to take. So it actually, when the Lymphedema Treatment Act became available, it narrowed down what we had available very quickly. I think at least in our region in central, kind of central eastern United States, we're seeing a growth of DMEs now willing to participate with the Lymphedema Treatment Act, but we're seeing a wide variety of demands. And again, we'll talk about that in a second. And then down the road, items are eligible for competitive bidding. Right now, my understanding is that's not being used, but it is a potential which might change the landscape of what our bill is. So when it comes to working with patients, right now I am spending a lot of time, and I'm encouraging all of my colleagues to spend a lot of time making sure we're getting those patients what they need that's appropriate, but also preparing them for the future because this bill can change, coverage can change, DME suppliers can change what they're willing to provide. And so getting your patients this coverage while they have it now is the best way to really protect them and insulate them for these changes down the road. When it comes to being a therapist, we kind of already talked about how the documentation demands are increased. The physician's notes are now a major requirement. There's been some understanding. I've heard some information from DMEs that I use where they're now coming in and they're now cracking down more heavily on the documentation standards. So whereas they were using physical therapist notes in the prescription, they're now wanting MD notes that clinically state that and maybe even assess the lymphedema. That's becoming more frequently required. Maybe you have a DME that doesn't require that yet, and that's fantastic. But just to kind of know that we're seeing the increased documentation demands kind of continue, not only just from the start of the LTA. These suppliers do have the ability to put limits on garments that the LTA didn't necessarily intend. So they might only use a specific brand or only provide certain items. That may mean that as people, we have to, or as therapists, we have to be very proactive. That might mean we have to use multiple suppliers to get the patient the items that they need, or we might have to kind of, if the garment company is willing to provide this baseline item, we have to be proactive in our documentation to really support the need for the extra things on that garment that patient would benefit from. The other thing is they can also change their ordering process and their options in regards to what they have available and what their suppliers are. Whereas we don't have that luxury. We have to go through these services. If you work at a place that doesn't actually provide its own supplier, you have to then know with these medical suppliers what they have available and what their process is, which is extra when we're constantly seeing the landscape of suppliers change right now. On top of that, we're seeing those DME options increase, but again, I'm in kind of central eastern United States. We are a desert. We do in our area, most of the therapists will do all of their own fitting and measuring, and we have to figure out ways to just kind of maximize that cost because we eat that cost otherwise, because we don't physically have a service within about 150 miles from us that actually does the measuring, fitting, and the billing for the medical garments. And so some areas, even though we're seeing growth in that supplier option, there are people who still are going to be working with their own self-driven, working with DMEs like through a online source to make that happen for their patients. Right now, one of the wonderful things about the LTA is prior authorization is not required, especially with the Medicare Part B stuff and the ones that follow Medicare Part B. That is a right now thing. We don't know what the future looks like. I'm hoping it stays that way because it's kind of wonderful. You check boxes A, B, and C, and the patient can get their garment. On top of the suppliers and the changes to the suppliers, I would love to know if anyone on here has some different information kind of at the end of this as we're taking questions. But personally, in our area and with a lot of our national suppliers, we are having awful time getting donning aids and doffing aids covered. A lot of times they tell us that the reimbursement rates that they get for these are not worth the actual, they don't actually provide enough reimbursement to make it worthwhile to bill it. So they're willing to take out-of-pocket pay and give a discount to the patient. But in many cases, things that the Lymphedema Treatment Act is actually stated to have covered, the DME companies in some cases are saying they're not actually going to go bill that treatment for that Lymphedema Treatment Act for it. And then fitting of codes, of course, I know this was a big thing when we all first got started because we're all still learning how to adapt with it. But the fitting codes are still non-billable, which is an unfortunate aspect of the care. But right now we're seeing patients get items that we never had before. So as far as the trade-off goes, I understand it's a huge impact and I don't want to underplay that at all. But we do have care for these patients and this bill is shapeable. So down the road, hopefully we'll be able to see some of these things change. I did pick up a couple of sources that working with some colleagues of mine and interacting with some people through power lymphatics that happened just in February, as well as a couple other things last year. I learned some things, and then I also was able to give some people some items. So I didn't realize a lot of people did not know that the Lymphedema Project has a supplier directory on their website. That it's not specific to Medicare stuff. It is lymphedema specific product. But if you go to Medicare's pages and you look up their suppliers provide information for all sorts of medical equipment, not just lymphedema compression garments. So this is what the Lymphedema Project has come up with it. And so suppliers put their information on it, and it gives you an idea of who might be in your area. Of course, it's not exhaustive. And of course, it might have incorrect information from suppliers that have changed but are no longer on there. But if you are looking for a supplier and you're looking for a place to get started, this might be a really good source for you. We are recording this, so this is ideally this is hopefully going up on the website, the YouTube page, and the Academy page. But if you can't find this access, feel free to email that LympSig Gmail, and I will be sending to you personally. So on other therapist resources, I had not known about this. There's a group that is a contractor for Medicare, and they actually do list what is approved underneath the LTA based on HCPCS codes. And so it's been really fascinating recently to look up items that not necessarily are common in my specific area. So I wanted to provide this to everyone because if you're looking for items that you need to know are approved and like what brands might fit with that specific HCPCS code, this might be a really great resource to check out to see. And again, is not exhaustive. There's a lot of major manufacturers not on this list, but it might be able to give you a good starting point on some options for you. And then the last resource I have for us is regarding denial reporting. This is done by the Lymphedema Advocacy Group. And for those who might not know, that is kind of the start of the LTA was Heather Ferguson kind of discovering in her area that she didn't have coverage. So she managed to get, I believe, the state of North Carolina to go through the whole process and get coverage for lymphedema. And then they've taken it on to the national component of Congress and getting involved with CMS. So this is their website, and their goal is to collect as much data on people who get denials for coverage. It is a pretty exhaustive thing. I filled this out a few times. It's very detailed. However, I would like to imagine that that detail is actually going to really help them show support for making changes to these bills down the road. So before we take questions, Ms. Paula, did you want to talk about the advocacy component that you're with the APTA real quick?
Yeah, I just kind of want to give you guys some updates on what is going on with this Lymphedema Treatment Act. And Candace, thank you so much for your wonderful synopsis and review of everything and all that's going on and all the work that you do with the SIG as well. But I did kind of want to just kind of update you guys, and then hopefully at CSM in February next year, we'll have a talk on that as well. But basically, the APTA, AOTA, the Lymphedema Advocacy Group, the Alliance of Wound Care Stakeholders, and the Compression Dealers Alliance met. We met recently again with CMS, with the policy group to discuss the Medicare benefit for the lymphedema compression treatment items. And so our group's primary focus is really to re-engage this group and on several issues, new and old, and a lot of the things that Candace alluded to within the context of, you know, we provided a survey. Many of you may have taken that, highlighting challenges with the benefit. One of them being payment for related therapy measuring and fitting services. And so CMS was amenable to the group's recommendation to carve out payment for fitting services from the bundled DME payment. If you guys are familiar, you know that the DMPOS kind of undermined what we were doing there and made it a very bundled service for fitting and billing for the garments, which, you know, most of us as therapists were fine with that because we just want to get the garments for our patients. But the group provided CMS with a potential modifier structure to kind of this is a long word, but operationalize this, because that's really how they talk. But CMS said that it would consider a change in upcoming rulemaking, but it did appear to indicate that the group's recommendation was feasible under the existing regulation. Now that's huge because you guys know how long it took to get this, and you know how hard it is to change regulations and legislation. So as far as measuring services, revisiting CMS's language in the rule establishing the benefit, it appears that they may not consider measuring part of the bundled DME payment after all, meaning that there is more hope that therapists who bill for related measuring services will not be violating Medicare's double billing provisions. So again, this is something, you know, we'll probably talk about it at CSM next year. Hopefully by then we'll have more information. Again, I think that us as therapists that do the measuring, we're more concerned just with our patients getting the garments provided. But it looks like they're, under the current regulation, it could be that we might get reimbursed for actual measuring. So another concern we have is the clarification of the existing policy. So we asked CMS to work with its Part C counterparts to ensure that Medicare Advantage plans are offering the benefit as required by regulation and statute. And just so you guys know, they do. The Medicare Advantage, Medicare replacement plans have to follow Medicare guidelines. So if they tell you that they will not cover these garments for your patients, that is wrong. They actually have to. So we sought clarification on the related signature requirements as well with these, because a lot of the Medicare Advantage plans are requiring a lot more paperwork than traditional Medicare. We didn't really receive clear instruction, but we did ask CMS to consider modifications to that signature policy and to review how DMEs have shifted the burden for their own payment requirements onto us, onto lymphedema therapists. And Candace alluded to the fact that, I'm sure that you all have probably seen too in recent months that the DMEs are saying, oh, now we need the signature from the physician on their actual EMR, not just the signature on your plan of care, that states why you need the garments. So I just want to let you guys know we're making progress there. And one last thing is more about new policy modifications. So we asked them to consider streamlining the DME documentation to relieve the burden that they have shifted onto us, to maybe consider setting uniform documentation forms based on minimum documentation standards. Oh my gosh, guys, wouldn't that be amazing? To consider an exception for the physician order signature requirement. And they indicated they'd look into this issue, and we shared statistics on how much this burden that this causes for us and how it's solely for the benefit of the DME. Because I know Candace alluded to the fact that, being in sometimes rural areas or areas where, we don't have DMEs that do the measuring. But there's also that same scenario where we as therapists do our own measuring. I feel like, and this is something when we originally with these groups I mentioned earlier and the stakeholders, and we met with CMS, that's how we got the 3 garments every 6 months, the 2 nighttime garments and the per body part. We presented all of that information to them. We also presented the fact that we are really the ones that need to be measuring for these garments if they are, especially if they are custom garments, because there is a time that it needs to be measured. There is tissue integrity to take into account. There are all the things that we do as therapists that I've done this for 27 years now, I think. So I'm telling my age, but I don't want to send them to someone else. You know what I mean? I want to do the measuring. So we do the measuring, we do the prescription of the garments, we send it, and we do that. And we're just thankful that it's being covered for our patients. But it is becoming more and more difficult and more time consuming. And you all that are on this call right now, you guys are like, I'm preaching to the choir, because you guys will spend that extra time that you do not get reimbursed for to do this. And so these are a lot of things that we're looking at, that we do the measuring and fitting. The other thing I was going to just mention, I was kind of taking some notes as Candace was talking, because she brought up so many things, including the donning and doffing aids or documentation. So when I do an evaluation on a patient who has lymphedema, even when I see patients who, for example, if we're exercising prospective surveillance with our individuals who have undergone a breast cancer diagnosis, and maybe I'm seeing them post-surgery to try to prevent lymphedema, I still put in my notes, because maybe they're going to be undergoing radiation and other treatments. I have a specific section in my initial evaluation that says that the patient will most likely benefit from blah, 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 blah compression, whether it's flat neck custom or whatever it is, and the reason and why. And then I also put in there the donning aids, because that is, again, that is included in the LTA, and that is something that is covered. So again, when you get backlash from any of the DMEs, it's covered. It is a provided benefit. And so as long as we document it clearly, those are things we should get. Sometimes I put it in there and then the patient doesn't get it. And then we have to go back and go, hey, it's in my note. And they're like, oh, shoot, we didn't send that. So, I'm just being very transparent here. Um, the other thing Candace mentioned about the HCPCS, and I wanted to bring that up because I think that what I hoped wouldn't happen that they said probably would since this LTA is that our private insurances are cracking down as well. And so even like HMOs and different ones are like, well, you need to send us the code and da da da. And I'm like, no, the DME needs to do that. But anyway, that's a great resource that Candace provided, because we do sometimes have to do that again above and beyond. But I also want you to realize, so a couple of things, and then I'll be quiet, is that your Medicare Advantage or Medicare replacement plans have to cover according to Medicare guidelines for these garments. They make it harder. We have to go through specific providers, and so I recommend that you get that you develop a relationship with the providers that you have in your areas. And I know if I have this one that has such and such, ABC Medicare replacement plan, I have to go with this provider. If they have, XYZ, I have to go with this one. If they have traditional Medicare, I can go with this one. Again, obviously offering the patient to go wherever they want to. But just remember that you are the expert, and that you are the one that knows that this is covered. And just put as much as you can in your initial evaluation, and then work. One more thing that Candace talked about is specific, like some of the DMEs have specific prescription forms. So we have worked with several of ours, especially the ones that cover the Advantage plans, to actually design it where we check the boxes and we get that form signed day one, so that in 2 weeks, when I'm ready to fit them with a garment, it's already signed, if that makes sense. Custom garment or, whatever I think they're going to need. So I think hopefully that gives you guys a little bit of confidence in the fact that we are making progress with this. And I think, legislation is so difficult. It took so long for this to happen. It went through 7 Congresses, which is 14 years. But I feel like our most recent meeting gave us confidence that the current legislation, the current rollout, actually can be read in different ways, so that I think that CMS is going to help. Is going to maybe look at it differently, and hopefully we'll make some progress. And hopefully by the time, if we get to present this at CSM in February, we will be able to update even more. Thank you.
That's wonderful, Paula. Thank you so much. I know Miss Paula is well known in our community and really represents a lot with lymphedema care, but she has taken this on and this has been a big to-do. It's taken up a lot of her life, but I understand that a lot of people, there are still some things with this act that we would like to see improved and improved upon. But just like she said, ultimately, when it boils down, our patients are now getting items that they never received before. Many of them were paying out of pocket or just foregoing it altogether. So the fact that we even have this that we can build upon is definitely optimistic, but anything to do with any sort of legislation is slow. So, and it's going to take a lot of our involvement bringing things to the light using denial reporting forms, or we'll ask Ms. Paul in a little bit about if there's any way she would like reporting for the APTA when it comes to any problems so that we can highlight highlight those to individuals who are representing us when they actually approach Congress and have these roundtables. So we did have some pre-submitted questions, and then once we get done with the pre-submitted questions, if we have time, I'll be more than glad to start opening it up to either chat or if people want to kind of raise their hand in the system, we can kind of look to see what's available. But the first pre-submitted question was, what is the next steps to making change at the LTA and what do therapists need to do? Miss Paula kind of already answered that one in her description. Is there anything you would like to add to that necessarily?
No, I mean, I think hopefully that I did kind of cover that. As far as what you need to do to help, email me, email Candace. We can, sorry, Candace, but no,
No, I'm
but
100% okay with that.
but truly you are. Yeah. And so any questions you have, any concerns you have, we got your back. We'll present those things.
So, and then I believe you also probably answered a lot of this next question as well, but what are the current focuses of change regarding the LTA from both the therapist and the DME's perspective? Really wonderful information. Honestly, I wasn't expecting to hear all of that. We had talked a little bit about some of it kind of on individual meetings, but just the fact that you all are tackling that, and we might even have an easier workaround regarding the fitting and measuring codes, that is really optimistic. I know, especially for people who work in private pay, that was a big issue. And so hopefully we'll see an answer sooner than actually changing legislation. We had one more question from a community member, and that was, how are CLT streamlining garment requests, specifically those that have coverage through their insurance like Medicare? Um, you kind of talked a little bit about documentation already. Do you have anything else you want to add to this question specifically, Miss Paula?
Well, I also I see some things in the chat that go right along with this. So I
Hmm.
want to make sure that we absolutely answer those questions that are in the chat, but
Yeah.
I think it goes right along with this. Um, I mentioned about and I think that's one of the questions about, what I put. So in obviously in your initial evaluation, you are documenting tissue integrity, circumferential measurements, stage of lymphedema, if they have lymphostatic fibrosis, if they have radiation fibrosis, et cetera, et cetera, et cetera. If they have truncal edema, along with their extremity edema, et cetera. I have a section under bandaging and compression garments and all of those sorts of things. So under the compression garments, I will document depending upon the patient. Like for example, it may be the first day I saw them, but I know that they have had an axillary node dissection. They're getting ready to start radiation, etc. They may not have lymphedema yet, but I know that I'm going to want my patient to have a flat knit custom compression garment for the arm sleeve. Okay. I know I'm going to want them to have a specific compression bra trunk garment. Um, so I will document that. And it's going to be specific to your patient. So I hope that answers the question about how do I know what to say on the eval. I think put it in there on that day that, that this individual will most likely benefit from da 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 due to extent of lymphedema, lymphostatic fibrosis, size and shape of extremity. Of course, if it's someone who's had changes in their limb size, because that's a big deal too, any changes, that gets coverage. And then I always put in there, and then the individual will also, the patient will also benefit from donning aids due to whatever, right? Range of motion restrictions, because most of them have it. Um, Size, of extremity, type of garment, all of that. So I don't know, Candace, is that answering the question, do you think, a bit?
Regarding the streamlining,
Yeah.
I do
Like
think it
if,
answers it quite well. The other thing is really taking this again. It shouldn't be on us. I'm not going to like sit there and say that it's okay that we're having to do all of this. but it is the reality of the situation right now for us to get our patient stuff. So we kind of have to make the best of that world work. So use your EMR to the best of your ability. I have a lot of pre-coded things, and we have a very specific EMR which lets me with a few keystrokes pull up pages of information. My the administrative team is okay with us building things as long as it gets approved. So it might be worth, looking at pre-making items, seeing if you can add HCPC codes to a generalized document that you can pick up, and now you just click, click, click. And keep in mind, you don't have to be aggressively specific. You don't have to know the exact brand, the exact everything. You need to know the generals. If my patient's dealing with hand swelling, I'm probably going to need a glove. I'm probably going to need a glove of this intensity. I'm probably going to need this laterality, and I might even need an arm sleeve. But those things that you can go ahead and kind of go ahead and pre-put in that documentation can save you a lot of challenge on in the end. And then, just like Paula said, changes can be accounted for. You are able to get remakes and able to get additional garments through the LTA if a patient has a substantial change. So if you have this plan and you get them moving forward and then something happens in between with new radiation or new treatments along those lines that warrants a complete new size change, you can use the LTA on the benefit of that and get them coverage. I have seen that been successful before. You just need to make sure that your DME is very clear on the understanding of that purpose. And I think that's probably one of the other things to work on streamlining. In our area, again, not to bear down to this point, but we do all of our own stuff out of necessity. I would like to think I would do it on my own if I had the option, but we don't know. Some days it's busy. But as far as it goes, I have multiple DMEs that I'm working with at all points in times. And a DME might be because this insurance works best through this if it's a private insurance, but it's also if I need this item, this DME has this item consistently. If I need this item, this DME has this item. If I need a certain speed, this DME is faster than this. So it's just, unfortunately, it shouldn't fall to us to do that, but I have a multiple page PDF document that my coworkers can utilize, and the goal of that document is to speed us up. Where are we having problems? What's getting denied? How is it getting denied? If there are denials, what advantage plans are we seeing at what percentage coverage? Things like that. And again, a lot of that work does fall on us, but if you create a good foundational base work, you might be able to streamline the process. The other thing I would recommend is maybe not rely on the DME to get the prescription for the compression garment. In our area, we do get a lot of our own network physicians, but we work with a lot of out-of-network physicians who have no understanding of this entire process, that don't even know that the Lymphedema Treatment Act is helping their patients. So we've created a generalized form letter that comes out, and we just copy that out and fax it to the providers not in our own network, but it comes back to us quicker. That office knows they've sent us that patient, so they know what we're sending is important. When they get the DME's prescription request, it probably goes in a stack with a bunch of other things that have to be signed, and it can sit there for a long time. And I've had providers in my own network say, is this important? Do I need to sign this? Because it looks very generic. So if you have a relationship with your referral sources, it might be worth creating a system where you can more easily get those referrals back to you. Because a lot of times the DMEs will say, oh, well, we're hung up on trying to get this garment covered or trying to get this approval process for the physician. Well, if you have the ability to go ahead and get those things on the front end, it is more legwork for you, but it does get things done faster. And especially if you have electronic EMR, you can utilize what you've put in your own note and literally just move it over to the prescription so that the doctor is signing the exact same thing in your note to make your life just a little bit easier.
So I do have templates too, like you were saying, Candace. Like I have templates and again, I put them in my eval. I know someone commented that you could also do it later in your progress note, which is very true. And I do it in my progress notes too. And I copy and paste. I don't copy and paste, but I copy over my eval to my progress note, so that each time it says, they need this, they need this, they need this. But I think anything, like you said, that we can do on the front end, if and we're talking specifically about the LTA, so this has to do with Medicare, but it has really affected our private insurances as well. But as far as Medicare, this is what you're going to need for the certain Medicare Advantage plans. This is what you're going to need for the certain, replacement plans. This is what you're going to need for traditional Medicare. And these are the people we can go through. And I know someone asked about, finding them. I mean, I've always worked in a community-based hospital-owned outpatient clinic system, even though it's a large organization with multiple hospitals across multiple states. Still, where I work, you know what I mean, is kind of a rural area, even though the population is about 50,000 people, but that's kind of how it is, you know what I'm saying? So like the different DMEs that we find are, like, I mean, we use the big names that I don't even want to mention a lot of them, but we know that for certain, it's a lot on our end and it's not okay. You're right, Candace. It's not okay. It shouldn't be on us, but it's what we do for our patients. And so I think you have to know what is required from each, in your area, what insurances you see, right? You know what you see most, even private insurance, but what type of Medicare replacement plans, who are the DMEs who do I go to if they're this one? Who do I go to if they're this one? Have that information. Some of them require a prescription form. Always have your plan of care signed. This is the other crazy thing I want to bring up is that the whole having our plan of care signed for Medicare patients. Remember how that is no longer necessary, but we still do it because now that's not required for PT and yet it's required for these garments. And so we just, on our initial plan of care, we send it to the physician to sign and they will sign it. And like Candace said, I will have sometimes the DME sends the doctor, can you sign off on blah, blah, blah. And they'll email me or they'll call me and be like, what is this? And I'm like, yes, yes, that's something we wanted them to have, but most of them just know if it has to do with compression that, yeah, they want it, you know what I mean? And they'll sign off on it. So
Yeah.
I think you just gotta be proactive and ahead of the game because I see the other thing that someone said about taking forever. I never thought I didn't have this problem when I heard people talk about it all the time about taking months to get their compression garments until the LTA took effect. And now I'm waiting sometimes 2 or 3 months for them to get their garments. And it's frustrating, but it is, so just as much as you can do ahead of time.
It's also beneficial for that reason to consider looking at multiple DMEs. One of the questions earlier was asking if that web page was the best way to do that. That is a good way for you to get a general idea of what's in your area, but you can look up Kentucky and there's very little in Kentucky. So we have to use a lot of sources. Honestly, your manufacturers want you to be billing garments. Contact your manufacturers, ask them if you have a rep who comes in representing a specific garment brand, ask them like what are you seeing in the area because they're going to try to hook you up with individuals or DMEs that are actively taking orders, and the more that you can kind of move. I have DMEs that I use before or around Christmas and I have DMEs that I use later on in the year because the ones that I might like to use more frequently are going to be so bogged down come Christmas that I just know my order is not going to get through, and some of them even have different cutoff deadlines, and so I'm having to navigate that whole process, and again, more work for us. But the more of it you're doing and the more of it you're taking notes when you're seeing changes, you're noticing things are happening, it really does help slim the process down and make it a lot less stressful. I still go to the fax machine and consider an office space moment where I might just beat it up one day. But at the same point in time, my patients are getting their garments. But yeah, if in regard to the DME component, if you're looking for suppliers, don't not only the web page, consider some of the national DMEs that have online services. If you are rural, but you have the access of electronic medical records that you can just send stuff straight in or do electronic faxing, however that works, that could also speed up your process. But then reach out to your manufacturers and they are your reps who might have DMEs that they can recommend that you use. We've received quite a few of our more regional DMEs through our reps contacting us and saying, hey, we have a new group here in town, consider using them. And then it's ended up being a very positive impact on our clinic.
And end of year too, we do get those deadlines from the DMEs that we use. Also, we started a while back emailing versus faxing orders because then we have a specific paper trail. And I see someone said something about putting it in your patient's hands, and absolutely, I tell them if you haven't heard from them by such and such date, you should call. And here's like I give them the phone number of whoever they choose to go through, and so that they can stay in contact. And then we also have like a specific DME that requires all this paperwork they have to sign. Like obviously there's HIPAA, but all these other things like, hey, you haven't received it from someone else, and it's okay for us to bill your insurance, yada yada. And so we keep a paper copy of that. That's another way to fast track it a little bit, because otherwise then they email it to the patient and the patient has to email it back. And so it's just one more thing that it might save a day, but or two, but a day or two is very helpful.
So looking through, Melinda notes that she's had clinicians say they may not know exactly what to prescribe for a patient on initial eval. How do I document with enough detail early enough to be proactive, but also allow for wiggle room? I think we kind of touched on that a little bit, but honestly, those templates, if you have the luxury of having them, are very helpful. And I have never been dinged for over documenting garments that we don't request. So I have had multiple times where I've sent stuff to a supplier and said, we want this, this, and this off of this order. We are not ordering this, this, and this. Because maybe I went in with this viewpoint for the patient. I had this idea, and the patient, after discussing with them and having multiple visits, maybe that's no longer appropriate. But as long as I have the documentation there for what I want, they're not going to penalize us for stuff on there that they might not want down the road. So literally a template that pops up when you do, say, for instance, lower body, and you have these options to kind of choose from. If you're over documenting, but it's a quick couple keystrokes on the keypad, that might be a little bit easier. But then there's always the option of changing things down the road. Just because you documented it that way at initial eval does not mean you have to stick with it forever. You can send in progress notes and reassessments as ways to justify garment needs through the LTA. So you can always make those changes. Let's see. And then I believe someone did do a shout out, and I will go ahead and do the shout out because if you are not familiar with the Stride article that's been done, I highly recommend looking into that. Power Lymphatics did have a section on Stride that I believe one of their authors presented on, but that is a great way if you are either not spending a lot of time in lymphatics or you need a good template for your documentation to help support garments. They have some great resources in their article. The article itself is a great way to explain compression to people because a lot of stuff, like considering how experienced I was in the world of lymphedema, I learned a lot more from that article that I probably should have already known, which was pretty scary. But it's a great article to read for both the upper and the lower extremity, but it also has some great general templates that you can work on adding into your electronic record or your physical record to kind of help guide you on components that support your documentation. Um, Another person asked about DMEs taking weeks, if not months. Is this a problem for other people? We kind of touched base on it and we kind of touched base on the ways to streamline. Yeah, I don't think it's a problem across the board, but I see it in my area come and go in waves. We'll have one DME completely overwhelmed or, the main people who do the billing go on vacation all at once. And so we're behind weeks. And so then we switch to this DME in that time period, and then we move back and forth, based on what the patient needs and what the patient has access to. Do you have anything to add to that, Miss Paula?
No, I agree with you. I think ours, again, we have specific DMEs that we use. We still have those struggles, but it ebbs and flows. It's like a roller coaster, unfortunately. Sometimes we'll be like, oh, yes, we're getting them on time. And then all of a sudden it's like, it's been 4 weeks and we email them and they're like, oh, sorry, that fell through the cracks or whatever. And I think it just has to do with, the way that things are. But yeah, just stay on top of it. It's all you can do. And I was going to go back to the documentation thing again, because I love what you said, Candace, about you can't like just saying that you think they're going to need it. Okay, it's in there. You know what I'm saying? And if they don't, they don't. So, like, for example, I might say specifically, patient will benefit from flat knit custom compression arm sleeve and glove due to size, length of extremity, extent of lymphedema, lymphocytic fibrosis, et cetera, et cetera. And then I will say, we'll measure for and fit with this as appropriate or as indicated or as decongestion is achieved. Like, you know what I mean? Like every eval that I do, I am going to address compression. And I may not know yet. And I might just go educated patient in compression garment options and we'll continue to assess need for this. But we pretty much kind of know what we think they might need. So if you go ahead and have that in there, and then on your progress note, you put it in there again, once you know for sure. So I just say document anything that you think they might need, and in the beginning. In the beginning, we have to get ahead of things because the time factor has just been huge with this.
Yeah. So another person just asked, what do you say to DMEs when they tell you that the Medicare Advantage plan does not have the same coverage? That's a good question.
Mhm. Okay, let me think how I'm going to phrase this. No, I'm joking. Um, okay, so what we know, according to what is actually legislation, is that they do have to cover. And that's something I didn't even in the very beginning when this went into play. And then the DMEs were like, well, no, they have Medicare Advantage. It's not covered. And so, I've worked with Andrew Amari, who is our payment and practice specialist, who's a lawyer by trade for APTA. And he said, oh, no, they have to. So the Medicare Advantage plans have to cover the same things that Medicare covers, even though it might be covered as a different rate. Does that sound right the way I'm saying it, Candace? Because I don't want to sound like I am a lawyer, but
No, yeah.
Medicare Advantage, Medicare replacement plans are also, I guess, mandated under the LTA to cover these items. They may cover it differently. That thing you said about supplements, that makes me think about supplements earlier. So if you have traditional Medicare and a supplement, the supplement covers as Medicare does. So that shouldn't be an issue. If it's a secondary, that's another thing. But
Yeah.
if you have Medicare and a supplement, then the supplement will cover what Medicare covers, their portion. But with Medicare Advantage, I mean, they talk about privatizing, Medicare or whatever. They are kind of like private insurances that maybe they cover 80%, or maybe they have a certain copay or a deductible. They still have to cover them
Mhm.
at that rate that the patient has contracted, just like a private insurance.
Yeah. So we see in our area, some of the Advantage plans cover at 96%, which is kind of great because sometimes when you look at an Advantage plan, you're like, oh my gosh, what am I dealing with? Oftentimes in our area, they have higher copays for visits, which is insane. So sometimes I get fewer visits because my patient can't afford to come in to the therapy, but I can definitely get them the best compression that they need. And it usually does follow the LTA. I wish I could say I'm like the golden child of advocacy, but when I run into a DME who's like, oh yeah, that doesn't cover that, I usually go, thank you. And then I send it off to another DME because, like I said, I have a small arsenal of DNEs. I'm typically at any given time, I have about five that I'm consistently using between different needs and things. And usually, this one doesn't have a problem with the Advantage plans. This one is really good coverage for anyone who might have a secondary insurance as opposed to supplemental. This one might be really good if I want a very specific item for a patient that these others don't have. And so it's really playing that game a little bit. I wish I could say I went back to the insurance company. It's like, oh, this is why you have to do this. Or not the insurance, I'm sorry, the DME. But this is why you have to do this. I will frequently tell them through just email exchange usually because that's how we operate. Like that's actually, the LTA is covering these items. The Medicare is covering these items. The Advantage plan should be covering these items, but I don't fight the battle that I should be fighting because I don't have enough time in the day. So. And then on top of that, the next part of that question is can the DME be penalized for saying that about a Medicare Advantage plans? And can we submit this complaint against the DME? I'm too lazy. I honestly don't know if that can happen.
So that's Renson. How are you?
Mhm.
I
Smart
miss
cookie.
you. I am going to say that this would be a wonderful thing to pass along to Andrew Amari. If you have something like this, then I could give you his email, and he's given me permission for this, by the way. Tonight, I invited him. I knew he has a lot on his plate for this meeting, but I would just say that's something that you could send along to them because that's why, I mean, this is APTA. He's an APTA lawyer for us, and let them do that. Do you want me to put his email in the chat, maybe?
I'm just gonna talk because I can only write so much. Um,
Hey,
hey, I do have his email, but I know the lymphedema advocacy group has that denial piece, but I don't know if this fits into that. And I have not personally filled that form out just because, like Candace said, I am just too lazy. But I feel like somebody needs to stand up to them because it's like they do whatever they want to do, and we move on to the next one because the next one covers it. But that's not right. They cannot dictate to us. We should be dictating to them, if any.
Absolutely. And don't say you're lazy, neither of you. It is that we spend so much time on this. It's anyway, I shouldn't say this, but it's like I always say, it's like sending someone to the grocery store and saying you have to buy this specific brand of this specific thing. Like we're just sending them business.
Hmm.
So they should be covering the brunt of the paperwork, the getting things signed, the et cetera. And we're trying to do this up front. So I do think you're not being lazy. You just don't have the hours in the day. And so I will bring this up though, to see if there's anything maybe we could include as a whole. Like, Candace was talking about the form you can fill out.
Yeah, there is a section on that form about this situation, not this specific situation, but where a DME, despite you knowing what the law says, the DME is not cooperating, and what you have done, if you've interacted with them to advise them on it and what they've sent back to you and things. So that is an option. But like I said, the advocacy group is a great way to do that. But like if you are part of the APTA and you have access to the academy, we can also pass it through to Paula and Andrew to get these things addressed personally as well. So don't feel obligated. That form is a great form to do, but people are tackling this from multiple sides. So it's not that you have to do one or the other. You can do both, or you can just kind of take your pick what's easiest for you. So we just don't want to add to your burden, essentially. And that is a great form, but it is a lengthy form. Just a heads up.
So
And
just to be
LaDonna,
clear, if a
go ahead.
company, sorry,
You're good.
No,
if a company is covering Medicare, they should be covering the Medicare Advantage plan. They're contracted to do that.
so not necessarily. So DMEs,
Mm.
just like us as healthcare providers, they contract with certain insurances. So that's a
Mm.
difference with the Medicare Advantage. We have traditional Medicare, we can kind of choose which of the ones to go with, right? But
Yeah.
so like I'm trying not to say specific names, but like I say, if I have ABC Medicare replacement, then I know that this DME is contracted with them. If I have
Mm.
XYZ Medicare replacement, I know that this DME. So no, they don't necessarily have to contract with them because it is kind of like, I hate to even use that word of privatizing it, but it is. It's like, it's like its own insurance plan. So
Mm.
versus traditional Medicare. Does
Yeah.
that make, I mean,
Okay.
is that,
Yeah, that answers the question because
yeah,
some DMEs have told me that we don't go with this Medicare Advantage plan, which I could
yes,
never understand. Like, you go with Medicare, why don't you go with this one? So
right.
maybe that makes sense.
It's just like private insurance. Like if they use this, or
Mm.
this, like just like us, right? If somebody comes to see you, like your institution contracts with certain insurances. So I have laminated things inside my cabinet above my desk that like this Medicare replacement or this DME covers da 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 da, and this one
Yeah,
covers these and this one covers these. It's I mean it's unfortunate and frustrating that we should have to do that, but we do.
yeah,
It is extra
Thank you.
groundwork, but if you have established DMEs, they'll
Yes.
tell you, they'll flat out tell you. They don't want to run the benefits on a patient and waste their time if they're not going to get the order. So frequently I have a couple of contacts where I'm seeing the benefits come back from the same person through these email systems quite a bit. So I'll just merely send an email and say, hey, I've got a patient with this specific Advantage plan. Do you all take that? And I think when I say there's a specific Advantage plan that a lot of us run into problems with, I have done that with pretty much every DME, and I had to find a different DME that provided that service. But
Same.
when they started covering it, they actually released this giant email to everyone who was on their network because they knew it was such a big issue. And they also know that's a big part of bonus for them. So yeah, those contracts are confusing, but it's a nuisance to have to call or email them and say, hey, I'm having these insurances right now. Which ones of these do you currently take? But it does save you on the long run if they'll actually send something to you and you'll be able to kind of start tallying who does what. Because again, they have the right to decide are they contracted. They just can't deny items based on coverage if they are contracted, saying, oh, that's not covered by the LTA. If they're
And
contracted, they're approved to cover it. So
And once you
Uh,
find them, then you kind of know because like you have the specific, again, it's regional, right? As far as insurances go. And it's the same with the different Medicare replacement plans. And so once you know, then you know, this is who I go through for this. This is who I send it to for this. This is who I send it to for this. And of course, it might change come January 1st, but at least we know that these are the companies they're contracted with.
Sorry, I'm dwelling on this thing. I apologize. I'm taking up your time, but
You're good.
I,
I think it's
I have
wonderful.
had the company come back that we cover this Medicare Advantage plan, but it only covers 4 units, which one, I don't understand what units is because that's not a Medicare thing. But what does it mean when they say only four? Like that's not in the law at all. So that is misinformation. I mean, I moved on and ordered it from somewhere else, but what does so they're giving me the wrong information, right? Because if you're covered as the law says. Okay.
Correct.
So one of
Yeah.
the times I've actually filled out that denial form, and when before last year, when you all are about to meet with CMS again, and you all asked for concerns that had been done, and you and Andrew got together and were presenting those, that's one of the situations I had ran into, is I was being told they had a different type of coverage altogether. And the interpretation of it hadn't come out to where people were saying that Advantage plans had to cover at the same rate. A lot of people were interpreting that Advantage plans could actually just be different altogether. So when I realized that, I went back, I actually contacted the patient and said, hey, I'm investigating this for you. So you might hear from me in a little bit, but just let you know there might be something available. But I ended up having to fill out that. That's one of the exposures that I had to that denial form is that they were telling me one thing that a lot of the people who were responsible for the advocacy of this were telling me something else entirely different. But then like
Correct.
I said, I switched to a different DME who interpreted it differently and had a contract, and it solved our problem after that. But that DME still is one that I will not file that specific Advantage plan with, just because I don't want the headache of having to deal with it when I know that DME A over here does. So,
And that the first 6 months of this rollout was a mess. The DMEs had no clue, honestly. They were like, we don't know if it means 6 months in a rolling year or January through May or June and then through and so there was a lot of those problems. And that was when I was hearing those things about that the Medicare Advantage and replacement plans did not have to cover it. And I contacted Andrew and he's like, absolutely, they do. Here's the law, here's the thing, you know what I mean? But then they kind of figured it out. But then I also wanted, LaDonna, if you're still on here, I see your question, and I have not had the experience with DMEs giving individuals garments before they're ever referred to us, and then they've maxed out their benefits. However, what I would say is that you the other part about that is the 3 every 6 months is also if there's a change in the extremity, then they can still be covered. And so when you, as the expert, see this patient and they've gotten something off the shelf, then it should still be covered. Does that make sense?
Yes, I guess this recently happened, and I feel like it's the DME company is starting to kind of prey on some of the vascular surgeons and doctors as a way of getting their patients compressions. And the doctor wasn't aware that it was billed that way. And then when they referred them to me, I was like, well, we can't get any more garments. So I just didn't know if that was something just happening in my area or other
Are
places in
the
the country.
inelastic garments, do you mean like the Velcro closure
The
garments?
Velcro closure garment, so it does give it some give, but like I just don't see why someone needs three of them when one would do, and we could have gotten two in two
Yeah.
flat knit garments. So
Absolutely. So
yeah.
I think that in that case, I would push for it because if the patient ends up coming to me after they've been fitted by a DME supplier before they were seen by the expert, which is you,
Mhm.
then I would say I would document there's, changes, there's document the fibrosis, any of the skin changes, anything you possibly can, the stage of the lymphedema, the size. I always put size and length of the extremity, that sort
Mhm.
of thing really justifies, I think, the need for those garments that we know that we custom fit them with, rather
Okay.
than them just getting something off the shelf. So I think that's a wonderful question. I'm sorry that you have experienced that, but
Okay. And I had one other question. You said that we don't have to put the specific name of the garment. Like if we're doing flat knit, we don't have to say that it's Jobst or it's going to be Medi. Okay, because I have a garment vendor who is saying you have to say the specific vendor,
yeah.
and I think that was
They
right.
try to tell us a lot of things we have to do that
Hmm.
we don't have to do. And again, that's the thing with me too, like Candace said, only having a few DMEs in the area that I can work with, and this one covers this and this one covers that, that I really do stay in very, constant contact with them about, nope, this is this, and this is what's required. And so they then work with us, even though they request it. But no, you do not have to put brand ever.
Okay.
One of our DMEs requests that we put, whether it's custom, I mean, they request their own specific prescription form. Even after I've sent my 8-page eval with all this stuff in there, I've sent the specific 2-page measurement form of custom garment or whatever. They still have their own prescription form, and so they want it to say custom. They want it to say the compression. That's the other thing. They often want the compression, and I say custom and ready to wear are apples and oranges, right? So when you
Right.
have compression class 1, 2, 3, whatever, but then you have a custom flat knit garment, that 1, 2, 3 is totally different.
Hmm.
And so, but anyway, so I've started for this particular DME I have to use for the particular Medicare replacement. I just write 23 to 36 or whatever it is, and
Okay.
I write it on it. But you do not have to put brand. Absolutely not.
All right. Thank you.
Now, what I will say on top of that, if you are okay with the DME deciding what the patient gets based on your measurements, that's a way that you can go. I don't put brand in my notes, but when I supply or I present for my order, like I have an order page that I provide, I do put brand because if I'm the one measuring this patient, we all know that there are some garments that fit certain measuring types, even if you're getting off the shelf. Some companies have options 1 through 12, and then other companies have options 1 through 4, and you might decide you need a specific type of an item. You do have to at that point put brand, but if you are just getting your early documentation done and you know this is going to be an off the shelf of this level, this laterality, you want the silicone band with features A, B, and C, that can be generic in your note and that can be generic on the prescription page for the doctor. However, if you want it specifically for the patient, you're going to have to make that request because a lot of these DMEs have not necessarily partnerships, but they have certain manufacturers they gravitate towards. And for
Hmm.
instance, there are some DMEs that will just put your patient in a very specific type of garment, even if it's not the best fit for them. So just kind of
So
be
I
on the
should,
lookout for that.
yeah, and I should definitely clarify my answer. I don't send my patient to any DME to get their garment.
Right.
I order it.
Hmm.
So I put that in my initial note that will be signed so that when I get to the point that I'm going to measure this patient for a flat knit garment, a trunk garment, a ready to wear, a cert or a Velcro closure, whatever, I ordered all of that. I just have everything signed ahead of time. So I'm sorry, I should clarify that I don't put specifically what I want in my eval, but when I send them the order, then they already have all that stuff signed.
Okay. That's fine. Thank you.
So the other thing that I think I didn't know this until someone told me, so I'm just going to tell all of you all at the same time. Um, if the garment you're ordering captures inside of that HCPCS code's compression intensity level, so say for instance you want a capri, and that capri captures within that duration, if it's a 15 to 20, If that 20 puts it in that Capri level, it is a covered Capri by the LTA, even if it might not cover the entire range. So we had a
Mm.
lot of pushback when we first got started with the LTA. I even, Miss Paula helped me out with this because I went to her with some questions about this and she was like, no, you should be good. Just keep forcing it and keep pushing it. And then at this point, I have two DMEs that will look at that order and say, okay, well, there's not really a Capri or a legging that fits this generic HCPCS code, these values. However, this one crosses into this value. So we can order A, B, and C, but we can't order D, E, F because D, E, F are actually below that value limit. So keep that in mind too. Your HCPCS codes don't necessarily fit compression class levels across the board. And so that makes it another complicated level we get to deal with. But fortunately, the HCPCS codes are a little bit more vague. So a lot of times, like when it comes to your inelastics, I believe the numbers like for the lower level is 18 to 30 mmHg. So as long as your inelastic falls in there in some manner, or is that your that's I think that might be minimum level compression for off the shelf. But your inelastics have no value because it's an inelastic essentially. So it's made to do multiple levels. So keep that in mind when you're looking at your items for your patient is that you may have a specific plan for the compression, but the HCPCS code is what that DME is actually looking at. And so as long as your numbers fit into that HCPCS code, you're good.
And I want to clarify too. I see in the chat about 4 units is 4 pieces, like 2 sleeves and 2 gloves. So again, whenever we were clarifying this with CMS and runs, and you were in on this as well, where we were like, they need this many per body part. So just so that you know, private insurances are whatever they are. Okay. But with Medicare and of course then Medicare, replacement advantage plans, that it is 3 per body part every 6 months. So that means 3 gloves, 3 sleeves, 3 knee highs, 3, capris, 3, compression bras, all of those things. 3 every 6 months. So that is the lovely thing about this, even though, we have to fight really hard to get them, that you can know, that you can get 3. I mean, they need at least 2, right? One to wash, one to wear. We shot for the moon. We asked for 4 every 6 months and they gave us 3 every 6 months. And we're like, yay, win. So, so just know that with that's specifically Medicare.
Does anyone else have any other questions? We're a little over, which is absolutely fine for me. I don't know about Miss Paula, but if there's no other questions, I'll give people a few more minutes and use this time to thank Paula again for everything she does because major cornerstone for our academy, but not only that, but the LTA when it comes to representing us there. But also for her time tonight because she was very generous. I think we played email tag for weeks trying to find an opening in her schedule. And she took another free day she had to do this with us. And so we really appreciate that because her schedule's just loaded, but she just cares enough to really provide this to us as a group. So we really do appreciate all your effort that you put into this and how much you support us as an academy. It really does mean a lot on behalf of our therapists and our patients.
Thank you. But you all, every one of you on here do the exact same thing. So I am thankful to be a voice. So you probably have my email. So any questions, any concerns, please reach out to me because it's my mission and my passion to, make this work for our patients. Thank
Yeah.
you guys so much.
Yeah. So, and just one last thing to everyone who might have hopped on later. We want to start doing these on a regular basis. We're looking at maybe every 3-ish months. If you have a specific topic you want broached or something you think might be interesting, please notify the SIG leadership. We're available on the Academy page, but you can also use that Lymphedema SIG Gmail that we send out in notifications to. But please let us know. We really appreciate everyone spending their time with us today and actually making this not only a successful discussion and having a lot of feedback and information, but people who pre-submitted questions too, so we could kind of plan the whole night. So thank you, everyone. I hope everyone has a great week. Try to consider joining some of the bone health, the osteoporosis, osteopenia information that's coming up this weekend. And we'll look forward to seeing you all at the next meeting. You all have a good night and thank you.
Thanks, everyone. Bye-bye.